etiology, pathogenesis, pathology of the lung cancers. Today I will do the best to finish the lecture, and in the practical class next to this week, we will start to discuss it. Now write please the signs and symptoms of the problem. If you written it the previous time, if I gave it, just listen me very quickly. We will speak about it, and then we will continue to the staging. Staging system, by the way, included in your final state exam, staging of the lung cancers. Today I will do my best to explain it for you. But let's start from the signs and symptoms. All signs and symptoms, as you remember, we divided into three main groups. And first signs, they belong to the primary tumors, which is located inside of the lung tissue, which is not spread outside of the lung, which is not goes to the mediastinum. That's a locus inside of the lung. Which kind of the symptoms we will see? Right, please, usually it is connected with irritation of the epithelial tissues of the respiratory system. Cough, pain, which is projected in the region of the thorax. Usually pain connected with inspiration, inhalation. Because the more you will inhalate it, the more pressure will be increased and the more it will be irritated. Second type of the signs, it is the erosions and ulceration of the mucous membrane and damage of the vessels and nerves. Yeah, why I say especially mucous membrane? Because if mucous membrane is intact, of course bleeding will be intraparenchymal. Yes. But if the mucous membrane is damaged, it will be bleeding inside of the lumen of the respiratory system. Yeah, of course it is hemoptysis, and it can be micro and macro, as I say you previous time. So both situations we can see. Sputum formation. Sputum can be inflamed, can be necrotizated. That's why we can see the necrotizated pieces, for example, hemolytical structures inside of the sputum, which is showing to the necrosis processes inside of the tumor, yeah? Especially, of course, for centrally located form of the tumors, yeah? Peripheral tumors usually doesn't give such kind of the symptoms. Now, right, please, second group of the signs, it is signs connected with spreading of the tumors, formation of the metastases into different regions of the human body. And first of all, guys, it is the general signs of hypertension. Hypertension inside of the mediastinum, hypertension inside of the cranial cavity, hypertension inside of the abdominal cavities, for example, retroperitoneal space. Second, what we can see, it is, goodbye. Second, what we can see, it is that generally invasion into the organs, invasion into the vessels, and formation the hematomas, formation of the organic failures, formation of, for example, pressure of the digestive system. Little after I will show for you X-ray with the barium swallow, which is greatly show, for example, pressure of the esophagus. Esophagus partly is closed because of the pressure of the lung tumors. Yeah, that's a different type of the signs. It's not necessary now to speak about all meningeal signs, or for example, all signs connected with the failure of the organs. Use your imagination, understand into which regions tumors can be spreading, which structures it can press, which structures it can damage, and because of it, let's imagine which kind of the signs and symptoms. For example, if it goes to the liver, we will have one kind of the symptoms. If it is pressed the heart, for example, in the mediastinum, we will have second type. And if it is located in the cranial cavity, it will be absolutely another group of the sign of symptoms. Even it's not necessary to describe. But in the state exams, of course, teacher can ask you. For example, which group of the signs we can have in case of intracranial tumors. But it doesn't matter, it is primary tumor or secondary. Signs will be absolutely same. Continue, please. Last group of the signs, it is the general signs. General signs. What does it show? It shows that this signs doesn't have any specificity. Again. This is the signs which doesn't have specificity. This is the signs which has happened, as I said you previously, because of two main type of the problems. Problem number one, hypoxia. Hypoxia can be happen or because of the pressure of the vessels or exactly pressure into the heart. the organ failure is formed. Because of this, you can see hyperproliferation of the connective tissue, formation of the periostitis, formation of the clumping, formation of the different type of arthritis, because in the region of the joints, you understand, mainly it is small joints. Yeah, like the rheumatoid arthritis picture. So we can have it. I show for you also science which is connected with production of the acute cells. Yeah, we say that there are endocrinological, mainly small OAK cell type of the tumors. They can product it some type of the adrenocorticotrope, diuretical type of the hormone, thyreotrope type of the hormone, different type of, even the lactotrope, prolactin, that's a different type of the hormones can be produced. For example, formation of Cushing, formation of the gynecomastia, formation of the toxicose, water toxicose, failure of the kidneys if antidiuretical hormone is produced. You can understand that very different type. This is the first. Second one, connected with the inflammation. Again, general science can have exact connection with inflammatory process. Why inflammation? If there are tumor, there are necrotization. If there are necrotization, there are intoxication. Idea is very simple, guys. Second reason of the inflammation, it is the formation of atelectasis. Centrally located type of the tumors can give the obstruction of the bronchial system. After of it, of course, 100% of the cases, pneumonia is formed. No any atelectasis without pneumonia. It's like if there are pneumonia, of course, there are inflammation, there are fever, there are all possible symptoms which you can imagine. I think it is also seen. And right, please, third type of the science, again, general science. They connected mainly with the metabolical problems. Because of the tumor growth, the person lose the weight, the person lose the appetites. There are general signs of the intoxication. All metabolical processes inside of the organism can be changed. So we can see serious, for example, the electrolyte balance, catabolistical, anabolistical processes. Tumor, usually, if you will see the persons with
Eating the
tumor, it will be cachectical persons. During the time they lose the weight. Let's continue now, right, please, the staging of the lung tumors. The categories is absolutely same, but about size of the tumor, right, please? T1. It is from 2 up to 3 centimeters. Let's say T1 grade, category will be better to say, divided into 2 parts. T1A, it is from a little bit less to 2 centimeters, and T1B, it is from 2 up to 3 centimeters. So remember, please, then we will speak about grouping of the stage. Grouping, it is, forms 4 groups. Yeah, yes, usually for another tumors also. We will speak about this graduation. Let's say T1 divided into 2 types. T1A, less than 2 centimeters, and T1B, from 2 up to 3 centimeters. Right, please, T2, it is generally sized up to 5 centimeters. Generally sized up to 5 centimeters. Again, divided into 2 grades, A and B. A1, it is more than 3, but not equal to 5. B1, it is up to the 5 centimeters. T3. T3, guys, this is, we can say, the bordering size. Bordering size. Usually we say more than 5 centimeters. More than 5, for example, from 5 up to 7 centimeters. Right, please. T3A. T3A. From 5 up to the 7 centimeters. But there are T3, 2, and 3, which is not written in our grouping. But what does it mean? Look here, please. Any size of tumor which is near to carina, more than 2 centimeters near to carina, doesn't matter into the size. It is become to the T3B. Let's say, if problem located near the carina, what is the problem of it? It can give the obstruction of the bifurcation. Even the small tumor can bifurcate it. Let's say, if it is at least 2 centimeters and more near to the carina, to the bifurcation, such kind of the tumor, despite the size, we describe as T3 and T3B. Second type of T, which is also very important, it is tumor which is made contact invasion into the thoracic wall. Again, here size is not important for us. We grade it as T3B. Let's say if there are contactly invasion into the anterior abdominal wall, by the way, into all another directions also. It can be contactly goes to the mediastinum, contactly pass to the posterior wall of the thorax, contactly pass to the diaphragm and to the liver. Let's say this is the contactogenous type of the metastasis. We describe it like as the T3. And finally, T4, distant metastasis. If between primary locus and metastasis, we don't have communication. Do you understand what the difference between contact metastasis and between distant metastasis? In case of contact, primary tumor and metastasis, which is spreading to the neighboring structures, have the communication. In case of distant, for example, hematogenous or lymphogenous, we don't have any communication between the primary tumor and between the final place of location. Now write please, grade M. N1. It is mainly intra-lung type of the lymphatic nodes, which is located in the tissue of the lung, or ipsilateral healer, one group of the lymphatic nodes, which is in the hilum. Remember about it. T2, again, ipsilateral, but usually more than two group of the lymphatic nodes. For example, hilar groups and mediastinal group, yeah? But only in the side of the primary tumor. T3, guys, it is contralateral sending. That's it. If the metastasis is passing the contralateral side, or if it is passed to not local group of the lymphatic nodes, for example, supraclavicular, for example, axillary, that is not the local group of the, you remember 12 group of the local lymphatic nodes we described. If it is go outside, for example, it goes to inferior caval lymphatic nodes. It goes to the jugular group of the lymphatic nodes. It is go to the ductus thoracicus. It's like that is T3 stage, then the problem is spreading outside of the local group of lymphatic nodes, or if it is goes to the contralateral side. That's both situations is possible. About metastasis grade, I think everything is understandable. 0, no. Distant metastasis. By the way, contact metastasis doesn't describe as M grade. M grade describe only distant metastasis. Remember about it. As a contactogenous metastasis, it doesn't forms the category M. It is forms the category T. Now write please the grouping of the tumors. Grouping of the tumors, about 0 and X, I think is. Then you listen the tumor grade 0. You must understand or the tumor is absent, or there are cancer in situ, which is impossible to diagnose by any instrumental methods. Cancer in situ diagnose only pathological. Remember about it. It's a, you use all possible laboratory methods, instrumental methods, except the pathological methods. Yeah. You don't find anything. You put the group 0. It means we don't find anything. It doesn't mean that tumor is absent. Maybe it is the cancer in the situ, as I said you before. Let's have a look here, please. Next one, right, please. Stage 1. What is the main characteristics of the stage 1? It is T1. It can be A on grade B, doesn't matter. T1, but no any lymphatic nodes involvement. Remember, please, lymphatic nodes in first, we can say group, it is absent. Lymphatic nodes is intact. Now, right, please, second one, stage 2. Here situation is different. Stage 2 divided into two groups, stage 2A and stage 2B. In case of stage 2A, size of the tumor can be up to 5 centimeters, but no lymphatic nodes will not be involved. In stage 2B, size of the tumor can be less than 2 centimeters, but we have involvement of the lymphatic groups, and it is mainly hilar or intra-lung lymphatic nodes. It is 2B. In stage 3, three-stage, guys, look here please, also it is divided into 2 grades, A and B. What the difference between them? Look here please, again, difference connected with size and lymphatic nodes, because in stage 3, we don't have any far distant metastasis, remember. Let's say 3A, right please. It is size of the tumor up to the 7 centimeter, but no any contralateral lymphatic nodes, and Karim lymphatic nodes also not involved inside of the tumor. Let's say Karim lymphatic nodes is intact, contralateral lymphatic nodes. 3B vice versa. Size is not so much important. It can be less than 3 centimeters, but we must to have contralateral signings and Karim lymphatic node signing. Also inside of 3B group included the contactogenous metastases into the walls in 3B. Contactogenous metastasis also belong to 3B. In the case of stage 4, I think everything is understandable. No importance to the size, no importance to the lymphatic nodes. We have distance metastasis. That's a 4th stage, that is the stage with the distant metastasis. Remember, please, again I mentioned, this staging system will be in your final exam. Especially it is question about it. Remember about it. Let's continue. Now write, please, the main methods of the diagnosis. Let's start from the laboratory investigations. Simple blood count. Usually, guys, in case of the simple blood count, we can see the problems with the white cells, and we see shifting to the left. Not so developed, but shifting to the left. We can see leukopenia, not leukocytosis, but leukopenia. Especially open the brackets and write, please. Leukopenia, it is, we can say, very characteristics for distant form of the metastasis, if it is last stage. In the first stages, vice versa, then the inflammation is developed, we can see leukocytosis. We can see leukocytosis. Also, sometimes we see the eosinophilia. This is also specific, you know, as eosinophils, usually we have in case of allergical reactions. Yeah. Here it is connected with, right, please, 2 factors, which is produced with the tumor cells. First one, it is tumor necrotizating factor. Tumor necrotizating factor. And second one, guys, it is some erythropoietic factors. Erythropoietic factors, which can, again, product acute type of the cells. Not the simple type, but acute type. It is small cell type of the cancers. And sometimes these persons have high hematocrit. So you can find, because of this erythropoietic factor, we can see high hematocrit. It is shown that there are some endocrinological type of the tumors. Remember about it. Right, please, about oncomarkers. I write here the carcinoembryonic type of the oncomarker, but remember, please, it doesn't use for diagnostical purpose. Carcinoembryonic one is great for prognostical cases, and to understand the value of the treatment also. There are tissue oncomarkers also. For example, epidermal receptors growth factor. It is pathologically can be find it, and it is mainly high level of it. It is resemble for squamous cell type of the tumors. Receptor growth factor, it is mainly specific for squamous. It is a smoking person's tumors. Twice, thrice, it can be increased comparable with the norm. Let's say this is exactly diagnostical form. For example, it is very important to detect it in case of cancer in situ, to understand which characteristics it has and how in the future it can be developed. But of course it is not circulated, it is the tissue on the market. Remember about it, please. Right, please, the main instrumental methods, of course, it is the imaging methods. And from imaging methods, the main, it is the X-ray. Especially, I put for you two pictures. By the way, again, I suggest you use the pictures which I included in these your words, because if from clinical sciences your level is little bit more than 0, from diagnostical sciences you are negative, friends, down to the 0. Then we tried during our state exams to give you simple X-ray, even normal, and ask you to show some structures which is visible in this picture. It makes so big confuse. Let's say here I show for you normal structures. In the right side you can see tumor. Inferiorly I put the same quality picture but without any knots. And you can try to self-independently understand what is it, which kind of the problem. For example, what the difference between these two types of the tumors, which is, that is solid one. Solid one, but it is also centrally located. As you can see, it is located in the level of the main right bronch. Second one, it is disseminated type of the tumor. That's why we can say that here, approximately by X-ray, we can put the stage, for example, 1 or 2 comparable with size. I don't measure. Here there are stage 3 approximately, because you can see the hilar lymphatic nodes, several groups involved inside of it. That is much more harder comparable with upper picture. Which kind of the signs you can see in the simple X-ray? Right, please. The main signs which is visible in the X-ray. Number 1, it is enlargement of the lymphatic nodes. Number 2, decreasing of the pneumatization inside of the lung, as you can see in the picture. No air. There are solid problem. Number 3, pleural effusion, usually in the side of the tumor. Number 4, it is pressure, symptoms of the pressure of the nervus phrenicus, and portional parallelism and high position of the diaphragm. Portional parallelism and high position of the diaphragm. Number 5 I show here in this picture. In this picture. That's it, right? I especially don't write any notes here, guys. Not because it's hard for me, but I give you a chance. I mentioned the problem and give you the chance to self-independently understand. What do you see here? Rib fracture. This is the rib fracture. That's why we have osteopathical some signs in the X-ray, which can be visible here. If you will look attentively here, you can see that the rib is broken. This is contactogenous type of the metastasis, the invasion exactly into the anterior abdomen, anterior thoracic wall, sorry. As you remember, it is the grade of the tumors T3. Then we have the contact invasion into the anterior abdominal wall. Up to the, for example, for females, up to the breast. For the males, just to anterior of the thoracic wall. So remember, why no? It is not mistake. It can be continuous to anterior abdominal wall also. Remember about it. What is shown here? Then, by the way, all the signs which I tell you before is visible here. For example, horizontal level. You can see pleural effusion. Also, you can see the decreasing of pneumatization. Here you can see high position of the right side of the diaphragm. It means the parallelism of the diaphragmatical nerve we have here. And finally, what is it?
Disseminate.
But what is it? What is it? This is secondary tumors, not primary bears. Usually this ball-shaped type of the metastasis, it is usual for the metastasis from the breast. This is female, you can see the breast. Let's say this is the metastasis of the breast tumors, which is give the ball-shaped type of disseminated. This is not primary tumor of the lung, remember please. That is very specific for breast metastasis into the lungs. Of course, you understand that no any surgical treatment. We will not provide it for such kind of patients. Let's continue. Except X-ray, right, please, we can use, of course, the scintigraphical method of the investigation. Scintigraphical methods of investigation. For example, here we use the scintigraphy of 3 regions together. This is the head, this is the thorax, and this is the abdomen. Usually we do it using the technetium. Technetium. And what do you see here? Liquids, which is content the technetium, heart,
Absolutely.
yeah, urinary bladder, kidneys.
Yes.
That is normal. That is not the tumor. Brain, because brain has the best vascularization, supply. Let's say organs, which is greatly supplied, will be visible here because inside of the blood we will have technetium, and in the X-ray it will be shown. But look here, please. Some abnormal structures, which is normally asymmetrical. Look in the opposite side, we don't have anything. But we don't have any great supplement region, only inside of one lung. That's why if we see asymmetrical accumulation of technetium in some part of the human body, we come to conclusion that this is not 100%, but the big possibility that this is the metastasis. Not only here, by the way, here also in the brainstem, here you can see, or inside of the vertebrae, it is hard to say for me. Is it the brain tissue or it is the vertebra? Mainly it is the bone, in my opinion, here. I'm not so sure about that point, not these points, because this is the biggest vessels of the human body, aorta abdominalis, and this bifurcation into the iliac vessels. But that point is confusing, especially because in the opposite side it is also, this is the from in front and behind. To say, maybe also there are the metastases in the pelvic bones. Yeah, you know, lung cancer with the metastases into the bones, into the bones. That is very specific. About computer tomography, again, what you can see, the primary tumor, solid tumor, in my opinion, by the form it is resembled to the adenocarcinoma, yeah? But a little bit I am confused by position of it because it is centrally located. Adenocarcinoma mainly, you know, you have peripheral location. It is hard to say. You can see the metastasis into the mediastinal lymphatic nodes from both sides, by the way. It is greatly visible. If you will look attentively, even you will see liquid in the posterior mediastinum. And X-ray of the esophagus, which I promised for you. And you can see that it is tense from behind. Yeah. I don't recommend it start from this kind of investigation. But anyhow, when we do it, for example, no any lung signs, but the person is mentioned that there are the problem with swallowing. Yeah, dysphagia, for example. Then in that case, of course, we start not from X-ray, we make endoscopical investigation. Yeah? And usually we will see inside of the esophagus some obstruction. The ball is prolapsed inside of the esophagus because of the exact contactogenous spreading. Even we can have, by the way, formation of the fistulas. Yeah, if it will have the wall of esophagus, we can have the fistulas. Let's continue, guys. Now about bronchoscopy. This is the gold standard method of investigation for centrally located tumors. By the way, this is the screening test for any person who has the problems with lung systems. What does it mean? If there are hematostasis, bleeding, 100%, not cough, of course. If you will go to the cough, nobody will not make for you bronchoscopy. But if there are bleeding, gold standard, bronchoscopical method of investigation. Especially if you are a smoking person, if you have anamnesis of the smoking. Remember, please, that is, for example, in our country, in all other countries which I know, if there are bleeding, endoscopy is strongly prescribed and recommended. What is shown here, in two upper pictures, you can see portional obstruction. Here even there are the bleeding. So you can see the mucous membrane is ulcerated. Let's say this is the reason of formation of the intrarespiratory bleeding and hematostasis. Yeah? In the posterior picture, the situation is 100 times harder because we have complete obstruction of the bronch. Of course, all inferior portions will be closed. We will have the obstruction. We will have atelectasis. Let's say that is, of course, the hard situation. Let's continue. Right, please. Next method, it is the endoscopical investigation of pleural cavity mediastinum. Usually, guys, we do it not separately, but it is the part of the VAT assistant surgery, video assistant thoracoscopical surgical manipulations. Let's say it can be thoracoscopy or it can be mediastinoscopy according to the structures which we want to diagnose. For example, mediastinoscopy usually you do for taking of the biopsy material, from mediastinal lymphatic nodes. By the way, usually it is descending type of the incision, 2 centimeters above the jugular notch of the sternum. We cut the soft tissues, and the scope is inserted along the trachea. Let's say sliding by anterior wall, to be very careful to not damage your jugular venous arch, which we described, because jugular venous arch is very dangerous. Then you cut it, you don't see bleeding because it contains negative pressure. As the arteria thyroideima, which also cut it and doesn't show any bleeding, not because negative pressure, but because it is descending to that. In case of endoscopy, it's not so much dangerous, because you will identify the problem inside of the mediastinum, you will clip it. But anyhow, that's how you can see that endoscopical methods of investigations, to take the biopsy, or to start the surgery like the diagnostical, then continue it like the curative surgery. The VAT assistant surgical manipulation. Let's continue, guys. Right, please, the treatment of the problem. Surgical treatment, it is primer treatment for the first stage, for the second stage, and it is combined treatment, usually for the third stage. Let's say primary treatment for first and second, main treatment. For third stage, usually we do combination. Which combinations I will show you after. Now, minute attention, guys. Contraindication to the surgery. Right, please. All contraindications divided into 2 groups.
Absolutely.
Pre-surgical and intrasurgical. If it is contraindication, it is absolute. Now, we don't speak about not absolute. If it is not absolute contraindication, it is not a contraindication. That's why we speak now about absolutely contraindications, but we can divide it into the pre-surgical, which we find before surgery, and intrasurgical, which we find during surgery. Right, please. First group. Number 1, distant metastasis, which is find it by diagnostical investigation. By the way, place of the distant metastasis is not so important. If there are distant metastases, minute attention. Curative surgical treatment we don't provide. Otherwise, that we can make the palliative surgery. For example, if there are the metastases into the larynx, we can make the tracheotomy, tracheostomy. If there are atelectasis with the long-term pneumonias, we can make the portional resections. But again, I tell you, this is not a curative surgery. That is the palliative surgery. It is not curative for the lung cancer. For the pneumonia, it is curative. But for the main disease, it is non-curative. Of course, you understand.
Just call it.
Continue, please. Parallelism of the biggest nerves. Nervus vagus, nervus phrenicus, nervus laryngeus recurrens. If we find such kind of the problems, we understand that the tumor located in mediastinum, it is spreading. Continue, please. Next one, it is the problems connected with breathing. For example, the pressure of the trachea, pressure of the larynx, or obstruction of trachea, obstruction of the larynx. It is also contraindication. About what Ziad say, if there are organical failures. For example, ischemical disease. I don't know what is the reason of it. Not only because of the pressure. Maybe it is just the
Dynamic, hemodynamic.
not only dynamic. Maybe it is another problem of this patient, another disease of this person, which is symmetrically passed with the main disease, That's it. I must to reach the compensation of the problem for the surgery. It is connected and for the kidney failure, and for the heart failure, and for the liver failure, anytime. That's why you reach the compensation. In that case, it is not the absolute contraindication. So I write it here because why I write? I write serious ischemical problems, which is impossible to treat medicamentously and to reach the level of the compensation. If you cannot reach the level of compensation, of course you prevent me making good surgery. Now write please, intrasurgical contraindications. Finding of any metastasis which is not previously detected by diagnostical methods. If you find the metastasis which is previously not detected. Invasion of the problem into the biggest vessels of the thorax. Contactogenous. I don't speak now about distant metastasis. I speak about contact form of the metastasis. Open the brackets, right, please. Aorta abdominalis, inferior caval, superior caval veins, pulmonary trunk, pulmonary veins. That is contraindication. If there are contact vein invasion inside of, why it's contraindication, guys? Usually such kind, if there are contact forms, they need to make, as I say, this third stage, combined form of treatment. Usually we must to make the neoadjuvant treatment to shrink the tumor, to localize the tumor, because if it is passed to the biggest vessels, you understand that any your mistake, little after I will show stages of the VAC surgery, how you will work with the biggest vessels. Now imagine that the vessel wall is abnormal. You touch to this vessel and the profuse mortal bleeding is originating. Of course, in that case, you stop your surgery. You decided which kind of the combination to do. Usually it is chemotherapy together with the surgical treatment. Little after I will tell about it. But anyhow, primary curative treatment is contraindicated. Right, please, the surgical treatment can be divided into three main types. Number one, the biggest surgical treatment we call pneumonectomy. Then all one lung completely is removed, together with all tumor processes, which is inside of it. Second one, it is the lobarectomy, or we call it lobar resection. Then you remove one lobe. And finally, smallest one we call segmental resection. According to technique of the surgery, we can make open surgical access, in the brackets right please, thoracotomy or thoracosternotomy, or we can make laparoscopical access. Again, we say it is thoracoscopy or mediastinal comparable with removable structures, which is need to be removed. All right, please, open incision, open type of incision. Before start to speak about access and specificity of it, guys, look here, please. According to this contraindication, which I described you before, finally, usually our experiences show that approximately 45% of all persons with lung cancer can be surgically treated. 45. Because another 55% have pre-surgical contraindications, which I mentioned you before. But from this 45%, during the start of the surgery, only half can have final resectional surgical treatment. For another half, usually we take the material of the biopsy if we find intrasurgical type of the complications and surgery is finished. So finally we come to conclusion that from whole patients with the lung cancers, not more than in 20, maximum 25% of the cases, we make primary resectional surgical treatment. Remember about it, 75% and little bit more patients treated not surgically or not only surgically. This is very important to remember. Now let's start. The main incision, it is posterior thoracotomy along the 5th intercostal space. A level it is from the vertebral line up to the middle axillary line in one side. strongly by intubation of the patient and switch off of one lung using artificial respiratory system. That's like one lung will breathe, second lung will be closed, obstructed. So remember about it. Seldomly we can use anterior thoracotomy along the third intercostal space, usually from parasternal line, again from middle axillary line, especially for the tumors which is peripherically located near the anterior surface of the lung. Peripherically located tumors near the anterior surface of the lung. About layers of incision, I don't have time now to speak. Topography of anterior thoracic wall and posterior thoracic wall. You know, sliding layers, own layers. Who forget, here is written. If here also you will not find the satisfying information, open your topographical anatomy and refresh your knowledge. By the way, in your state exam question, there are 3 or 4 questions, if I don't mistake, about lung cancers, and inside of one question is written topography of the lungs also. I don't give it here because you see, even without it, there are 45 slides. So we must be responsible to study these problems. I don't give it, but you must know that topographical questions also will be included inside of it. So to be ready. This is what about I told you before, yeah? It is intraoperative type of the complication, spreading of the tumor. This is the metastasis, which is not found in pre-surgical stage of your treatment, yeah? If you find some surprise inside of thoracic cavity, for example, before you put the stage 2, no any contact metastasis, you open the thoracic cavity and you see that the problem is spreading into contactogeneously into mediastinum. From stage 2, it is become automatically to the stage 3. On stage 3, as I say, you primary doesn't treat it by the surgical treatment. Yeah, we need to make the combined method.
But doctor, that time you should take biopsy.
Then
Then
you
you
know,
can.
if you open, take the biopsy if you need it, of course. If you don't, take it before. If you take the biopsy before,
No, doctor.
comparable, what do you want? If you want to verify you, for example, and to take one more biopsy, you can do it.
No, doctor. For example, you find in mediastinum.
Let's say here you must think about one problem. Is it the lung tumor or not? If you primary make the, for example, biopsy, you know that it is squamous cell type of the tumor. For what you need to take the tumors and from mediastinum also? It will be 0.1 cases if there are 2 tumors together. One mediastinal, for example, second is lung. But of course, it is even stupid to speak about it, yeah? I don't know. If after the car accident the person is died, you don't think about the liver failure. Generally, you think about the exact problem, yeah, which you see, which you know. If you want, take, yeah. After, don't say our teacher is forbidden to take such kind of. Now, right, please. Intraoperatively, we can use the newest type of the technique. We call it molecular imaging methods. Molecular imaging can be divided into 2 types, guys. One, it is using of the target forms of the colorings, which is connected specially with the tissue structures of the tumor. For example, with receptors of the tumor. Much more useful it is for hormonal type of the tumors because it is very simple to provide the dye using some hormones which is connected with the receptors up to the tumors. Unfortunately, for another type, let's say for small cell tumors, we have today target type of the coloring. For another type of the tumors, for example, adenocarcinoma, we use not specific type of the colorings, yeah, which is accumulated in all tissues. But why more inside of the tumors? Because of the better vascularization. For example, you look to the lung tissue and you see that in some part of the lung, color is little more than in another type. That's it. By high possibility, you understand that this is the level of location of the tumors, and you see the borders. Generally, I want to say, guys, 2 times in our hospitals we use this. I want to say you that, in my opinion, it is not resolved. I will explain you why. Because Anyhow, generally you make the big surgery. For example, you make pneumonectomy. What will give for you the picture of the place of this tumor? Or you make the segmental, or you, in case of spreading tumor, yeah, if it is spread from several segments, you will make pneumonectomy. If it is inside of one small bone, you will make lobectomy. If it is, for example, cancer in situ, you will make segmental resection. That's it. I don't know what does it gives. Maybe better visualization, maybe in future. For example, we have the special type of the resections, which we call the portional resection of the bronchial tree. Yeah? Then you resect it small piece, intrasegmental resection. Usually we use it in cancer in situ only. You remove not all segment, but portion of it. And then you make the sleeve form of the anastomose between removed and not removed portions of the bronchial tree. Yeah, you understand what I mean? That's a, 11 segments. Yeah, yes. That's a, you make not the complete segmental resection, but you make portional segmental. I don't suggest you to do it. I will explain you why. High risk of formation of the tumor embols of the vessels. For example, experiences show that in case of sleeve resection, recurrence possibility of the cancers twice more than in case of the big resections. But till now, especially in developed countries, time to time I read that, for example, in the United States, provided this sleeve form of the resection with long-term chemotherapy, yeah, to kill the all cancer cells. Guys, don't forget that chemotherapy by itself, it's not so good thing. Don't forget that this chemotherapy has 100 different side effects. Let's say, what is better, to remove one lobe or to remove piece of segment and then make 2 months the chemotherapeutic treatment? It is very speculative question. Which treatment will be less dangerous also? In my opinion, big surgery it is much more better in that case than small surgery, big chance of the recurrence of the tumor, and long-term chemotherapeutic. Anyhow, you will decide. I will show for you that this is also possible. Technique of the surgical operation. Right, please. In case of the big pneumonectomy, mainly we make incision which is open for us the mediastinum. For example, sternotomy or thoracosternotomy. Anyhow, you must to open the middle mediastinum, which is contain the bifurcation of the trachea. Here there are rules, guys. Then you make resectional surgery of the lung. You must to leave minimal short stump of the bronch. If it is possible, you must to not form any stumps. You must to cut the bronch from the place of its origin. Why, guys? Our experiences show that long stumps, long it means 1 centimeter and more, approximately in 20-25% of cases, necrotizated in the future. Because then you cut the tissue of the cartilaginous tissue. You know, cartilage doesn't have so good supplement as the soft tissues. Let's say you damage the vascularization. And in the stumps, usually we see formation of the necros with opening of the fistula in the future. For example, mediastinal fistula. This is the problem. Let's say we try to make the removing of the bronch without leaving of any stump from the root. If I want to work from the root, guys, again, I don't have time now to remind you topographical anatomy, but remember position. Position of the elements in the right root and in the left root different. From up to down, you know, here we have the bronch in right side, then we have artery, and below the artery we have the vein. In the left side, situation is another. Upwards we have artery, mid side we have the bronch, in front and below the bronch we have the veins. And remember, please, doesn't matter which size of resection you do. Write and mark, please. First of all, we must ligate and suture the veins. Remember, please, this is the rule. Pulmonary veins should be ligated first. Why I tell you before? to
What
prevent
goes?
formation of the embols from the tumor cells. Because that is the vessels which is provided blood from the lungs. That's why they can simply hematogeneously spread all the tumor cells. Imagine, guys, then you cut the tumor tissue. Anyhow, you can say, but sir, we don't cut the tumor tissue. We remove the structures inside of the health tissues. But anyhow, yeah, of course, you don't cut just the tumor tissue. But you are not sure that these tumor cells doesn't spread it even in the place of your resection. And of course, then you cut the tissue, you damage the vessels. It's like before any cutting of the tissues, you will close the veins, pulmonary veins, to prevent any passage hematogeneously of the problem. Right, please. Point number 2. You must ligate arteries. Why? Why?
No.
By the arteries, embols cannot be formed because the blood flow is to the lungs.
Yes.
To not remove the lung with big
Blood.
amount of the blood. You understand me? The more quicker you will close the arteries, the less blood to get. What is the lung? It is the sponge. That is the sponge. But previously, I remember, for example, my teacher teach me that before making of the complete resection, before the ligation of the bronch, he say press the lung tissue to move the blood, but it is forbidden, guys. Why? Because then you make the pressure. As I say you before, the cancer cells can retrogradely go to the blood inflow, venous flow. And you understand that veins has a lot of the anastomosis. Let's say this is for other case if you do, for example, resection in case of trauma. In that case, yeah, of course, to evacuate the blood, you can put your hand, you can press the lung tissue by the venous structures. The structures, blood will go to the, but not for the tumors, not for echinococcus. If there are the problem which can be spreaded hematogeneously, don't make such kind. It's much more better to remove this blood and to make the transfusion than to have the residue of the tumor in the different and other places. Remember about it. Now look here, please, in the picture I show for you beautiful pictures with, this is blood assistant exactly surgery. Picture A, number 3 structure which you see, it is the pulmonary vein. Exactly the right side. In the left side here you can see pulmonary, clip of the pulmonary vein, clip of the pulmonary artery. In the inferior pictures you can see what is it? Tracheal bifurcation, guys, you see, number 1, carina. Exactly, we remove now the left bronchi, yeah? They say the left bronchi here, right one, vice versa. And up to it, you can see aorta large. Do you see? Aorta large, guys. 1 minute, look here, please. It is surrounding aorta large. If I will draw aorta large, and then descending aorta, here will be trachea. Look. Let's say, of course, like this, yeah? Aorta large, partly surrounded left bronch, not the right one. Let's say, then you work in the left side, look so near. This is your bronch, which is ligated and cutting in the picture. That is aorta large. Let's say you must, in the right side, again I say, that is not so critically hard. But in the left side, they touch to each other. Let's say you must be very careful. And what I say you before, guys, no any stumps. And for vessels, and same for the bronch. You see how bronch is cut? No any stump. Usually in the bronch, guys, we apply 2 layers of the suture. First layer in the mucous membrane, second layer in the cartilages and muscles together. Say, by applying of 2 layers of the sutures, we make the absolutely, we can say, separation of the rest air from the neighboring cavities tissues. In the vessels, guys, you know more better than me. 2 ligatures in the proximal end, 1 ligature in the distal. For the VAD surgery, no any ligatures. We apply metallical wires. For the metallical wire, even 1 wire it is enough. to completely stop the bleeding and to prevent any secondary bleeding in the future. It's comparable with technique. In the open one, as I teach you, first is loose, second is strong, yeah? In proximal end, and just one ligature in the distal end. In case of the VAD surgery, you apply the wires. Remember about it. Guys, very quickly, time is very short. Now look, if you make, guys, the lobectomy, bluntly, you know, fissuras, yeah, the horizontal one, oblique one, bluntly, you open these fissuras, you know, inside of the fissuras, the pleura doesn't fuse to each other. Let's say you can bluntly open it. Only there are one exception, if there are inflammation. In case of inflammation, usually it gives the stitches. No any problem, guys, ligate it. But then you see there are dense threads. In 50% of the cases, they vascularize it. Before cutting of it, ligate it from two sides, then cut it. Finally, if inside of the groove you will go to inside, you will come to the elements of the lung. It is the bronch, it is the artery, it is the vein. How you identify the pulmonary vein? By pulsation. Pulmonary vein you identify here by pulsation. Yeah, because arterial blood goes exactly to. Let's say, remember please, you bluntly come, how much? Up to the reach the elements. Then you reach the elements, same rule, guys. Maximally short. Try to, what does it mean? For example, this is main bronch, you know, yeah, in the right side it will give 3 lobes, in the left side it will give maximally near the root. Don't leave any stumps to prevent formation of the fistulas in the future. Samely one segment. Samely. You open the, here just you cut the tissue because we don't have any grooves here. You find the segment of structures. How we do it, look guys. First of all, we have automatical suturing machine of the lung tissue. You apply the lung forceps into the place of the segment. They completely press the lung tissue. After this, let's say 2 forceps is applied. Between 2 forceps, you cut the tissue of the lung together with segmental bronch artery, and then separately you start to ligate it each element. You understand or it's not? Look, for example, this is the lung. For example, I need to make the apical resection. Yeah, upper, 11 seconds. What I do, first of all, I apply 2 lung forceps, which is press the tissue, which is arrest the bleeding. Then I cut this segment completely. Then proximately I find the elements, segmental bronch, segmental artery, segmental vein, and I ligate it, all of them. After ligation of the elements, I ligate it also all lung tissue to close the small bronchioles and alveolus and prevent formation of the pneumothorax in the future. Because if will be a communication between the respiratory system and between the pleural cavity, pneumothorax will be happening. Let's say 2 layers of the suture also we apply. We don't remove, by the way, these forceps. Along the forceps we apply continuous suture. Then assistant open the forceps and start to remove. You will tie the knot from 2 sides. So you apply non-interrupted. Remember, please, in the lung surgery, we don't use the interrupted type of sutures. We apply only non-interrupted suture to completely press all cutting surfaces to prevent formation of the pneumothorax in the future. This is about surgery. Now write, please, the radiotherapeutical treatment. I don't find any literature which is described this treatment as the primary one. Radiotherapeutical treatment mainly used or with the surgical treatment or with chemiotherapeutical treatment. Usually dosages is more than 5,000 Gray. Only there are one case, then we make low than 5,000 Gray. It is in the case of the palliative treatment. If there are distant metastases, but for example, tumor gives the obstruction of the respiratory system. If you will use the high dosage of the radiation, it will have the immunosuppression and this person anyhow have the huge problem with the organ failures, that's usually for them, we use not more than 4,000 prays. Right, please, during the week, we make from 3 up to 4 seances of mainly external beam radiotherapy, and continuation of the treatment, it is approximately 4-5 weeks. From 4 up to 5 weeks. In the case of stage number 3, usually radiotherapeutical treatment used as the post-adjuvant, or you can say adjuvant treatment after the surgery, together with the chemotherapy. 1 minute attention, guys. You can say how we can choose which adjuvant treatment to use, chemotherapeutic one or radiotherapeutic one. Idea is very simple. Right, please. In case of chemotherapeutic treatment, that is very strong. In case of chemotherapeutic treatment, we mainly prevent formation of the hematogenous type of the metastasis. Let's say if you come to conclusion that this tumor, for example, it's located near the big vessels, and during your work, there are, or generally because of the development of the problem, there are the high possibility of spreading of the tumor hematogenous. You understand that the chemical substances, which is used for chemotherapy, safely by the blood, will be spreading. Vice versa, if there are the problem with local metastasis of the tumors, it is lymphogenous, inside of the lymphatic nodes. In that case, much more preferable radiotherapeutic treatment because you can targetedly make the radiation of some locus. Let's say, sometimes guys, you mix and say, who in the future will tell me what is more better? Nobody. You must logically understand if you will work in this sphere. For example, first of all, you will have a lot of protocols. But generally, if you need to make your own decision, you must understand what do you want to prevent. Generally, why we make radiotherapy adjuvant and chemotherapy? Generally, to stop. Look, you say it, but to stop possibility. Because as I say you before, in the case of the metastatic tumors, we don't make primary surgical treatment. Let's say you try to prevent possibility of formation of the metastasis. Because if metastasis is formed, you will make palliative, chemotherapeutic and radiotherapeutic. It's not be primary treatment. And it will not be associated with the surgical curative treatment. You understand? Yes. For example, stage number 2, there are involving of mediastinal lymphatic nodes. I remove one lung. I remove how it's possible lymphatic nodes. Of course, you understand that to remove all lymphatic nodes, it is impossible. Now, to prevent in the future, possibility of formation of the recurrence of tumor, I make external beam radiotherapy in the level of the mediastinal lymphatic nodes to prevent any future metastasis. Or, during my surgery, I see that there are for example, big vessels which is open, gives, for example, irrigated vessels. But you are not sure. Maybe some 2, 3, 5 cells, tumor cells, patient goes to another regions, by the hematogenous way. Or, for example, you ligated the structures, but unfortunately not completely, and it gives the bleeding in the region of your surgery. If there are bleeding, there are high chance of the spreading of any tumor cells inside of the vessel. Of course, you will use the chemotherapy. Usually 4 drugs together you will use. Little after I will show you. I will speak about it. 15 minutes, it's enough. Let's say remember about it, please. Continue. Next one, right, please. Palliative radiotherapy, I explained. Yes. There are distance metastases. If there are distance, for example, what you want to reach here. Mainly 2 effects. Effect number 1, open the respiratory ways. If there are for example, obstruction of the respiratory way by same lymphatic structures. And if it is impossible, for example, it is located near the carina. Sorry, if it is near carina, I cannot make tracheostomy, because all my levels which I will open will be above the place of obstruction. Tracheostomy will be below the level. Sorry, if the carina is obstructed by carinal lymphatic nodes, which tracheotomy I will do? That's what I will do. Palliatively, I will try to decrease, for example, 4,000 Gray during, but it is long. It is long, not just I say you before 3-4 weeks, but we do it usually 2 months, for example. Yeah, longly, prolongly, we influence into these lymphatic nodes to maximally shrink. This is first. Second one, mainly, guys, if there are the pressure into the mediastinal heart, and if we have the ischemical problems, and we understand that this is ischemical problems which is connected with the pressure of the heart, and there are high risk of the tamponade of the heart. That case also, yeah, we need the target influence into the mediastinal lymphatic nodes maximally to decrease the size of them and prevent the heart failure. Right, please, chemotherapeutic treatment. Gold standard, guys, right, please. Cyclophosphamide, adriamycin, methotrexate, and cisplatin. This is 4 medicines which is we use full line therapy, and mainly, you know, chemotherapeutic treatment we use for the squamous cell type of the tumors, because as I say you before, squamous cell type of the tumors has high metastatic grade. That's it. But in the same time, we know that non-squamous cell type of the tumor, for example, large cell type of the tumors, is much more usually spreaded by hematogenous way. Because generally investigations show that squamous cell type of the tumor mainly spreaded lymphogenically. And adrenocarcinoma, vice versa, hematogeneously mainly spread. Why? Because it is located peripherally. There we have a lot of the vessels. And it is small vessels which can easily be perforated, for example, by the tumor growth, and simply the metastasis can go. But anyhow, remember, experiences show that in majority of the cases, chemotherapeutic treatment and this full-line treatment, which I say you before, we use for the squamous cell cancers. And it is, I can say you guys, usually, you know, I don't want to say it, but usually, then we compare the survival of the persons without chemotherapy and survival of the persons with the chemotherapy, especially if it is metastatic stage, yeah? Approximately difference is about 3-4%. That's if for 5-year survival, yeah, for example, in case of just surgical treatment without chemotherapy, yeah, or if we make palliative treatment, approximately, I say you before, yeah, near the 10%. In case of using chemotherapeutic treatment, it is 11%. What about it say? It say that really then there are metastases. Unfortunately, no any effective treatment, generally effective treatment, which is really increase the survival of the patient. Till now, we don't have. So you should do your best to treat this problem before formation, to make primary surgery, for example, with adjuvant chemotherapeutic treatment. But if you make primary chemotherapy, usually it is in the case of non-operatable type of the tumor, because if it is operatable one, why you don't operate it? So if you make primary tumor, unfortunately, difference between non-treated person and treated person in the case of survival, very small, miserable. But you understand that this chemotherapy in the same time can apply huge of the side effects. This is generally the person with immunosuppression because of the tumor. And you make the chemotherapeutic treatment, which is much more suppress immunity. It's like I highly recommend it to make, for example, chemotherapy as the adjuvant treatment after the surgery. But as the primary treatment is very discutable question. This is hard to say for me, and I cannot highly recommend it for you. About immunotherapy, about hormonal therapy, for example, the method of injection of the Bacilla calmette-guerin, tuberculosis bacilla, inside of the tumor. What does it give? Necrotization of the tumor. But unfortunately, there are necrotization of tumor. At the same time, we have formation of abscess of the lung. Abscess of the lung till now have approximately same mortality like the cancer of the lung. Let's say, what is the better? I'm sorry, I don't want to say it, but to be died from the cancer or from the huge abscess of the lung, this is disputable question. Laser therapy, it is not a separate form of the treatment, it is type of the surgical treatment. As we studied together, oncosurgery has special methods of technique. Plasma knife is used, the laser knife is used. What is good, guys? Laser knife has one advantage, coagulation. Then you cut the tissues, in the same time you close the small vessels. Then you close the small vessels, you prevent passage. No, guys, no, bleeding is not so big problem here. We prevent formation of the hematogenous metastatic embolus, which I said you before. That is the problem. They say, hey, friend, we need something interesting. No? I think you speak with our Prime Minister, Nikol Pashinyan. What can be more important for you than this lecture which I read for you? Vinit, last time you see result of your control. It is continuous from my second year. You know my attention to you. You're a great person, good person. But you don't study because you don't listen. About secondary type of the tumors, read please. Of course you understand that in secondary metastatic tumors, for example, look into these two pictures. Disseminated type of the metastatic and ball-shaped form, which I say usually metastatic of the breast cancer. By the way, next my lecture will be exactly about breast cancer. Of course, in that case, only palliative surgery, nothing more. Usually we don't use here. From three methods which I say you, just only the radiotherapy can be widely used because no chemiotherapeutical results and no surgical results we will not see here. And of course, symptomatical treatment. Yeah. Prolong the life and make it comfortable how you can. Because these persons usually have the problem with the breathing. Yes. This is the hypoxia. So you maximally try to make the ventilation of the lungs. Yeah, how much are it possible? Questions?